Thank you, Dr. Fukuma, and thank you to the ISC for the invitation to be here. Besides West Cancer Center being in Memphis, we can claim the birthplace of rock and roll, and we are also the home of Elvis Presley, or we're the home of Elvis Presley. Okay, so I'm going to bring the U.S. perspective, and really what we're looking at in terms of discussing this trial is percutaneous cryoablation as a primary treatment for low-risk early-stage breast cancer. And the real question is, are we ready for that? So in the US, we're always asking the question, can we do less? And we know that there are trends in breast cancer removal surgery that have gone from Halsted radical mastectomy to the days of the modified mastectomy, the total mastectomy plus radiation. And then Dr. Veronese and Dr. Bernard Fisher in New England Journal of Medicine in 2002 showed 10-year results, and then later 20-year results that showed breast conservation was equal to mastectomy in controlling breast. But do we have to remove the tumor? And that is going to be the question. Trends in axillary surgery have just mirrored that for tumor removal, from the extended axillary dissection associated with the Halsted radical to the level 1 and level 2 dissection, to the recent development and acceptance of sentinel lymph node biopsy for axillary staging. We have a baby boomer aging population, and you can actually see how that has changed here. And in 2050, it's expected that there will be close to 80% elderly patient population. And what about breast cancer in the elderly woman? If you look at the chart, you will see that new cases, 62.3%, represent 55 to 85. In terms of the axillary surgery, that's been a big question. There are 2 studies that show that axillary clearance is not needed. This one in 2006 showed no disease-free survival, overall survival between patients that received and did not receive axillary clearance. And then Dr. Martelli in 2012 looked at elderly patients, 65 to 80, stage 1 breast cancers. They had quadrantectomy, whole breast radiation, and tamoxifen, and there was no overall survival difference related to axillary clearance. There was also no breast cancer mortality difference, and there was no distant metastasis. That has led in our country looking at what about sentinel lymph node biopsy? Does that need to be done, especially in an elderly patient population? This program, Choosing Wisely, created by the American Institute of Internal Medicine Foundation, was to have doctors and physicians communicate and actually question commonly used tests and procedures and whether they need to be performed. This led to the Society of Surgical Oncology publishing in their list, don't routinely use sentinel lymph node biopsy in clinically negative women over the age of 70 with hormone receptor positive stage 1 breast cancer. What about emitting radiation? CALGB 9343, that looked at patients with lumpectomy and tamoxifen with or without radiotherapy in women over the age of 70 with hormone receptor positive stage 1 breast cancer. Despite a small change in the, let's see here. Okay, there we go. There's a small difference in local recurrence rate, but there was no statistical significance at 10 years in the survival rate of these patients. So we are actually looking at other trends in breast cancer treatment, really related to tumor biology. So much so that the 8th edition of Staging has included the biology of the patient in the staging manual. Genomic profiling has changed the way we approach the endocrine cancer, showing us that not all patients need chemotherapy. So this has led to further evidence that we could potentially eliminate the routine use of sentinel lymph node biopsy as well as the emission of radiation in the elderly patient population with hormone receptor positive stage 1 breast cancer. Are these trends happening? We can actually see, especially over here in the elderly population, that mastectomy is going down, lumpectomy alone is going up. What is our experience with cryoablation? We've had 20 years experience with cryoablating fibroadenomas. The American Society of Breast Surgery had a consensus statement published in the year 2000 that it was a safe, efficacious, and durable procedure for treating patients with fibroadenomas. Early studies of cryoablation, this was a systematic review published in 2015. They looked at 200 articles and then they narrowed it down to these 7. And most of them were done with ultrasound guidance. The numbers of, some were prospective, some were retrospective. The numbers were not very large. But you can see that a lot of these studies had good, complete local tumor control, and those that looked at cosmetic outcome showed that there was good cosmetic outcome in 100% of the patients. The overall local control was down to 73% because of the 2 studies on the far right. But you can look at the study and they were, one of the studies did not control for extensive DCIS, and the other included everyone over the age of 18. So they didn't have very specific criteria in these studies. The most significant or last study that was published on cryoablation in breast cancer with excision was the ACOSOG 1072 published in 2016 in the Annals. And we were looking at tumors less than or equal to 2 centimeters. They had needle core biopsy proven carcinoma. They had ER/PR HER2 on every case. They had imaging, mammography, ultrasound, MRI. They went through ablative therapy. They were then had a follow-up or post-ablative MRI before going for surgical excision. And it's not moving forward. The results, the cryoablation was successful in the excised tumors, excised specimens of showing tumor kill in 100% of the patients with tumors less than or equal to 1 centimeter, 92% when they were less than or equal to 2 centimeters. The multifocal disease was what was found to limit the success rate and needs further evaluation. They also had an endpoint of looking at MRI and its value in predicting whether or not cancer was left behind. It had an 81% negative predictive value. The presence of enhancement did not indicate positive pathology. So the ICE3 trial, the hypothesis is, can cryoablation be a non-surgical alternative to lumpectomy? So breast cancer surgery in the elderly can be challenging at times with increased morbidity, resulting stress to the family. This is a minimally invasive office-based procedure that can be done under local anesthesia, and there's essentially no pain. The patient goes home after the procedure, and you can easily monitor the ice ball with ultrasound and prevent damage to the skin and the muscle. The scientific advisory board included several in the leadership of our society. The idea, the overview was women over the age of 60. Initially, the protocol was 65, but it was soon brought down to age 60 at the request of the investigators. Lesions less than or equal to 1.5 centimeters. There's low-risk cancer, ER/PR positive, HER2 negative, low grade, and intermediate grade. Clinically lymph node negative. We left the option of treating the patient to the physician, and we looked at this as the replacement of the lumpectomy. So if they were a candidate for a sentinel lymph node biopsy and the surgeon would normally do that, they would do that. If they would not do it because the patient was over 70, they had in this trial the ability not to do the sentinel lymph node biopsy. So it was a non-randomized single-arm trial. There was no control group, 19 sites. It began in 2014. 206 patients were enrolled and treated in this study. The follow-up, standard of care, 6-month, 12-month mammography, then annually every 5 years. Look at patient anxiety with the NCCN distress thermometer, and look at patient and physician satisfaction at each visit. The outcome measures, the primary one was ipsilateral breast tumor recurrence, but we also would look at regional metastasis, distant metastasis, overall survival. The imaging modalities, MRI was optional in our patient population. So a unifocal cancer that can be easily visualized on ultrasound with the criteria that we've discussed. And the methodology was with the iSense or the ProSense system. Percutaneous, local anesthetic only, bringing the liquid nitrogen, the temperature down to minus 180 degrees centigrade, and a freeze, thaw, freeze cycle. So we visualize the lesion, measure it after biopsy and right before the treatment, measure its distance from the skin, guide it into the center of the lesion. Here is your lesion. You want to see the distance from the skin, which you see here. Then you're going to measure its dimensions. You're going to prep the skin, get ready for your procedure, inject local down to the lesion, make a little skin nick, and insert the probe under ultrasound guidance. And you can see the probe going here parallel to the chest wall, and putting it in the center of a very small lesion does take some ultrasound skill. Watch the ice ball develop, as Dr. Fukuma illustrated, and using saline to keep it away from the skin or the chest wall until the growth has gotten to the point that you are satisfied. 35 to 40 millimeter ice ball, and you want to, after the thaw, do the refreezing again and have the same measurement, and it's much quicker to get back to that measurement on the second freeze. And then you extract the probe. So there was 197 patients where data could be evaluated. They were all infiltrating ductal, low to intermediate grade. They were all ER positive. 92% were PR positive. They were all HER2 negative. And these were small tumors, most of them less, the mean was less than a centimeter. The adjuvant therapy, 21 received whole breast radiation. 1 patient received chemotherapy. 89 patients were prescribed endocrine therapy. 8 patients underwent sentinel lymph node biopsy, and 1 patient was sentinel lymph node positive, received radiation therapy, and it still has not recurred. There were 206 patients treated. 9 were found to not meet criteria. 197 were available for the analysis, but we've lost some to follow up, and it's not really that we lost them. We know exactly what happened to them. This is an elderly patient population. Some of them died from other causes. Some of their physicians moved. Some of the patients got other health conditions that limited their ability to do follow-up. So we are following 100 of the patients being followed, the 172, 78% have been followed for longer than 6 months. 61% longer than 12 months, 35% greater than 2 years, and initially at this first time of this publication in October of 2018, there were only 6%. As of July 2019, we have 35% of the patients that have completed 3 years, and we have 2 clinical recurrences of those patients. We look at quality of life, reported to be no pain in 97%. Most of them returned to work, and there's high physician and patient procedure satisfaction. You setting the expectations of the patient, you got to tell them that they're going to feel a lump. You educate them, they're going to feel a lump maybe when they didn't even feel one before you did your ablation. That's the reactive fat necrosis that occurs, and we can see that in this patient right here. And we use tomosynthesis in our patients. Most of them are fatty replaced, and we don't feel that MRI adds a tremendous amount in this patient group, but you can see at 6 months, there's some fat necrosis. And you will see here that with tomosynthesis, you can rule out a mass formation. And then 2 years later, it's 50% decreased. This shows you the evolution of fat necrosis around the clip. And it was mentioned, the radiologists need to get used to what it's going to look like, just like they did with fat injection. So in conclusion, it's a fast procedure. It's minimally invasive, superior cosmetic result, excellent physician and patient satisfaction, cost-effective procedure, and very good safety profile. And it's a promising procedure with acceptable and promising short-term results. And as we say in Memphis, thank you. Thank you very much.